No, please.
No, go ahead.
Okay.
Because just I wanted to give an information about the new classification that the ECRS committee. No. I just want to tell them the new classification of the ECRS for they made a big paper, and just to make it, because as you see, it's a lot of things confusing. So they divided it, and the new classification depends on functionality directly. So it's like what he ended up with the table, sort of this. So just to know.
It has been published in
ECRS
Journal of Refractive
last
Surgery.
year.
But it's a very nice classification because it's based on the functionality of the IOLs, but it's a little bit difficult to understand. So maybe we need to polish.
Multiple
Yes,
times.
we need to rethink about them.
What changed is that I made it more easy to understand.
Yes.
Because when you understand this functionality, yes, you can go through.
Yeah.
You can go more.
It's not easy. Yes. The full range, the partial range of is not easy. So, hello, my name is Montserrat. García. I'm from Spain, and it's a pleasure for me to be here. So, thank you for your invitation. I will talk to you about the IOL selection in patients after corneal refractive surgery. During the last 30 years, millions of patients have undergone corneal laser vision correction, and with aging, these patients develop presbyopia or cataracts, and these post-laser patients tend to have high expectations and motivations for spectacle independence when they undergo cataract surgery. The diffractive trifocal IOLs offers the highest rate of spectacle independent outcomes among the currently available lenses, and my talk will be focused on them because the trifocal IOL may currently be the most widely implanted type of IOL for presbyopia correction in both virgin and post-laser corneal eyes, and with the most experience published. But the patients with prior corneal refractive surgery have traditionally not been considered good candidates for a multifocal IOL, owing to the existence of increased higher order aberration induced by the laser interacted with the diffractive optics of the trifocal IOL. However, some studies have reported successful outcomes with the trifocal IOL in patients with prior laser. So in this patient, a correct patient selection is mandatory, and for this purpose, the corneal tomography is a powerful screening tool that will help us to recognize which corneal imaging patterns are or are not compatible with toric and with presbyopia correcting IOLs after corneal laser. So the first step is to recognize if we have a regular or an irregular astigmatism, and the ideal candidates for recommended toric IOL after laser should be those eyes with regular bow tie corneal astigmatism within the central 3 mm zone, eyes with a difference of 0.75 diopters of less in the corneal astigmatism magnitude measured between 2 biometers, and eyes with difference of 15 degrees or less in the astigmatism meridians from 2 lectures. Also, the topography is an important tool to identify some prior refractive surgery complication that could compromise the optical quality following cataract surgery, and that could be potential or even real contraindications for a multifocal IOL. For example, a small ablation zone, a decenter ablation, obviously a corneal ectasia, and we need also to detect dry eye patients. In these cases, we need to treat them aggressively in the pre-op period before selecting the IOL model. And also, we need to quantify the level of higher order aberration, because placing a multifocal IOL behind an unaberrated cornea runs the risk for an additional loss of contrast sensitivity and loss of lines of correcting distant visual acuity. But unfortunately, today, there's not comprehensive guidelines that exists for determining which level of total higher order aberrations makes laser patients suitable candidates for multifocal IOL. So in these cases, it would be reasonable to use the same preoperative consideration than for virgin corneas, using a tentative cutoff value in the total corneal aberration measured at the 4 mm zone less than 0.3 microns. How about the coma? Regarding the review by Moshifar et al., these authors recommend to avoid multifocal IOLs when the coma is higher than 0.5 microns. And also, we need to check this spherical aberration after the surgery, because we know that after myopic LASIK, the corneal spherical aberration increase directly, and this increase is directly correlated with the amount of diopters corrected. But in hyperopic laser, the corneal spherical aberration tend to decrease, and in some cases we will have patients in which the corneal spherical aberration is near to zero, to plano, but in some others we will have a negative corneal spherical aberration after hyperopic LASIK. So in these cases, it's important to match the corneal spherical aberration with the IOL model selected, independent is a multifocal or a monofocal IOL. So in post-myopic laser patients with positive corneal spherical aberration, the recommendation is to use a spherical IOL model that has a negative spherical aberration in order to counteract with the positivity of the cornea. In contrast, in post-hyperopic patients, it will depend on each case. If you have a patient with a corneal spherical aberration near to zero, the best IOL model should be an spherical with a neutral spherical aberration. But if we have a very negative corneal spherical aberration, another consideration is to use a spherical IOL if it's available in your country. In Spain, it's difficult to find them. But which is the maximum value of corneal spherical aberration compatible with a multifocal IOL? Unfortunately, there's a lack of empirical evidence to support any threshold value, but some surgeons avoid or recommend to avoid multifocal IOLs when the prior correction is higher than 4 to 6 diopters of myopia, 3-4 diopters or hyperopia, or when we have a negative corneal spherical aberration. So I'll show you some cases. This is a post-myopic LASIK with a well-centered ablation, a large ablation with a low amount of total higher order aberration and with a low increase in the corneal spherical aberration. So it's a good candidate for a trifocal IOL. Yes, even diffractive, yeah. But in this case, with a decenter ablation, a high amount of higher order aberration, and a moderate increase in the spherical aberration, this is not a good candidate for a diffractive IOL. So based in these tentative cutoff values, if we analyze the literature, the results of trifocal IOLs in post-myopic laser are very, very good. In this paper of a Spanish group, they compared defined vision in comparison with a monofocal IOL in post-myopic laser patients. We found comparable results in terms of uncorrected and corrected visual acuity, and also the results in the trifocal group in post-myopic patients were comparable to those obtained in virgin eyes. The first publication with EDOF models are statins. It is a recent publication, also a Spanish group, with a VVT IOL model of Alcon. And they show that the results in these cases were comparable also to the reported in virgin eyes, and even obtaining a smoother defocus curve in the LASIK group. But we compare the results in the trifocal IOLs in post-myopic laser versus post-hyperopic laser. We show that post-hyperopic LASIK, the results with the trifocal IOLs are significantly worse in terms of correcting visual acuity. We have a risk of losing lines of correcting distal visual acuity. In fact, these authors in their study conclude that if we have a low positive or a negative corneal spherical aberration, these patients should be considered with caution before implanting a trifocal IOL. So I show this patient. This is a post-hyperopic LASIK, a well-centered ablation, moderate amount of higher order aberration with a negative corneal spherical aberration. In my opinion, this is not a good candidate for a trifocal IOL, but if we decided to put a trifocal model, choose please a model of trifocal IOL that has a spherical aberration neutral. But even if you select a monofocal IOL, we need also to select an IOL with a spherical neutral or even a spherical aberration, with positive spherical aberration to counteract. Okay, and finally, I show you this case. It was come to our clinic. We're referring blue revision after cataract surgery in another center, and I think that the problem in these cases was that the patient has a clear negative corneal spherical aberration. They decided to put a monofocal plus IOL that Ehans and Johnson & Johnson work with negative, try to compensate the full spherical aberration of a virgin cornea. So the sum of those spherical aberration was the problem to the blue revision of the patient. So please, in this patient's cautions with all the models that have spherical aberration negative. And the last only 10 seconds. So, in conclusion, given the absence of the objective criteria and guidelines, the data to date suggest exerting cautions offering multifocal IOLs to patients that had undergone corneal laser. The multifocal IOLs may be used in eyes that had well-centered ablation bed, more regular corneal astigmatism, and lower amount of higher order aberration. In contrast, patients with pre-existing highlight aberrated corneas, negative corneal spherical aberration, extensive laser photoablation, or patients with a corneal retreatment cannot be performed should be better candidates for a monofocal IOL, or maybe we'll see in the future the role of enhanced monofocal IOLs in these cases. And today we assist many patients that exist in a yellow zone that does not exclude them for multifocal IOL, but places them at a risk for a less than ideal outcomes. So we will see also the role of the EDOF IOL in these cases. Thank you so much.
Thank you. Dr. Sonny Goel with us. Okay. Corneal presbyopia management.
Thank you so much for the opportunity. I think this is my last talk for this myome. I think all top presbyopia correcting talks was, I think, good.